cardiac problem or anomaly that can cause some vegetations, okay? So number one, you can have congenital heart disease. Number two, if you have any rheumatic heart diseases. So these are the most common congenital problem that can have vegetations. So when you say it's infective, there's already presence of vegetations, okay? Inside, so endocarditis, so inflammation also inside your endocardium. So sometimes it can be caused by your immunologic, infectious, and it can be sometimes caused by your embolic processes. So it involves your heart valves, if there's presence of any septal defects or any mural endocardium. So when you say it's endarteritis, okay, this will be infection of your arteriovenous shunt or your coarctation of your aorta. It's from the artery, arteriovenous itself, okay? It's different from your endocarditis. So we have different classifications of your infective endocarditis. We have native endocarditis in IV drug abusers, or you can have your prosthetic valve endocarditis. Native valve endocarditis, meaning, let's say, if you have rheumatic heart diseases, then there is already destruction of your valves, okay, from the native valve. If you have endocarditis in IV drug users, okay, they have this infective or vegetations to those patients who are using yung mga addicts, okay, mga IV drug abusers. When you say it's prosthetic valve endocarditis, meaning this patient has already underwent any prosthetic valve surgery and causing these inflammations. So what are the different causes of your infective endocarditis? We have two types, okay? We have your acute and subacute infective endocarditis. When you say it's acute, these are most commonly caused by your staph aureus, okay? They are actually rapid and they are destructive and they produces metastatic foci. So they are usually fatal in less than 6 weeks if they are not treated. And they usually involves your normal valve. For the subacute infective endocarditis, commonly caused by your viridans strep. So sometimes those patients who have damaged valves already, like in rheumatic heart diseases, they can present with subacute infective endocarditis. So meaning they can have these symptoms and they do not produce metastatic foci and it takes more than 6 weeks or more or even a year to be fatal. Okay, very, when you say it's subacute, hindi siya ganon karapid just like with your acute infective endocarditis. Sometimes you can have this prolonged fever and then you can only diagnose them if the fever is unknown origin, okay, and then you're having this prolonged fever and then when you do your blood culture and then it shows positive blood culture and then you have to look for you have to do your non-invasive imaging such as your 2D echo so you can see if there's any presence of your vegetations. So for your native endocarditis, there are 75% of them are mostly caused by your viridans streptococci. 20% strep bovis and other strep by about 5%. So viridans streptococci, they are normally inhabitants of your oropharynx. For those patients having a native valve endocarditis, they are more common in males more than 50 years of age, uncommon in children, and 60 to 80% they have predisposing cardiac lesions. Okay, the most common valve that is involved is your mitral valve compared with that of your aortic valve, and 30% of them are caused by your rheumatic valvular diseases. When you have right-sided endocarditis, the most commonly affected valve would be your tricuspid valve because from the right side itself, okay, yun yung usually involved, mga valve when you say it's infective endocarditis, okay? So for what about patients who have congenital heart diseases? It occurs only about 10 to 20%. So let's say if you have PDA, VSD, TOF, coarctation of aorta, pulmonic stenosis, those patients having bicuspid aortic valve, okay, they can have this kind of endocarditis. However, for patients with mitral valve prolapse with concomitant mitral regurgitation, 10 to 30% they can have this endocarditis. So some patients, okay, mostly what you can see for patients who have mitral valve prolapse, okay, they usually present with palpitations, especially in younger populations, okay, and then they are more common in males. However, for degenerative heart diseases, so meaning ito yung mga matatanda na, okay, mga elderlies, sometimes they can have this calcific aortic stenosis, which is sometimes you can have this syphilitic aortic valve, okay, with arterioarterial or arteriovenous fistula. However, 20 to 40% of patients who have endocarditis have no underlying heart diseases. So what about endocarditis in IV drug abusers? So patients who are addicts, okay, they are frequently occurring in young males. And the most frequent source would be your skin, which is 50% caused by your Staphylococcus aureus, 15% by your strep and enterococci, fungi, let's say candida and gram-negative bacilli in 10% each. Okay, sometimes they occur, they have multiple organism involvement, and the most common valve that is involved in IV drug users will be your tricuspid valve by more than 50%, followed by aortic valve and your mitral valve. Okay, so 75% of those with tricuspid valve endocarditis are secondary to your Staphylococcus aureus. Of course, if there's presence of your endocarditis on your right side, what will be the most common exit? So sometimes they present with pulmonary embolism, okay, and then they can have this pneumonia, although murmurs are sometimes or frequently absent. So what is vegetations? Okay, these are echogenic densities, okay, that are oscillating lesions which arises on your valves, endocardium, or anywhere inside your heart, okay? And what happens? This bacteria will adhere to your platelet, fibrin, and fibronectin, okay? So pag makikita nyo siya onto the echo, you can see it's like a mass, okay? But it is mostly attached to the valves. Okay, let's say if this patient has rheumatic heart diseases, you can see the valves are very thickened, and then some vegetations actually attaches to your on the area where there is less pressure compared with the higher pressure. Let's say on your mitral valve, they are usually located on the atrial side than the ventricular side. Okay? So if there's presence of vegetation and this vegetation will be dislodged, it can cause embolism. Okay? So it is very, once you saw vegetations on your 2D echo, and you have to correlate it clinically, and then you treat the patient accordingly, because there are some indications wherein these patients might need surgical interventions, especially in the presence of large vegetations and in the presence of recurrent embolizations. Okay, actually I have a patient, 19 years old lang. This patient actually seen by a cardiologist, and then she was treated as having rheumatic heart disease. So they started her already on medications or regimen for the rheumatic heart disease. However, prolonged fever, she complained actually of prolonged fever. So she was referred to a rheumatologist. So they are considering actually some immunologic or some hematologic problem. So this patient was also referred to hematologist. And then the fever actually intermittent siya. So it comes and goes, and then no follow-up already done by the cardiologist. So after the pandemic, wala na siyang follow-up doon. Then the patient actually deteriorated. So when she came to my clinic, okay, they started her already on some steroids because they are thinking it's more on hematologic problem, okay? When I saw the patient since first time lang na makita ko, and then when I checked, there is presence of murmur, which is very at par. Actually, there is disparity of these clinical symptoms from the laboratory and even the echo findings. So what I did is I repeat the to the echo, and then it showed actually a large vegetations. And then during the admissions, these patients presented with some embolization. So there was presence of there is already presence of acute limb ischemia because one of the vegetation already been dislodged to the lower extremities. So there is no perfusion already. The blood pressure is actually dropping. So this patient became septic. So I have to transfer this patient to the Philippine Heart Center, wherein embolectomy was contemplated. However, during the transfer, okay, the acute limb ischemia actually progressed. And then instead of embolectomy, once they arrive at the Philippine Heart Center, they already amputated her legs. Okay. However, I started already these medications on low molecular weight heparin. Okay, just to open up the clog or the obstructed arteries. Okay, and then na-amputate siya. After that, she's doing well. However, they are already preparing this patient for valve surgery for the mitral valve replacement because of the large vegetation. However, unfortunately, this patient succumbed to death because after a while, she went into respiratory distress. So respiratory acidosis, so went into arrhythmia, cardiac arrest, so hindi na rin siya na-revive actually. So once you have vegetations on your 2D echo, you have to be very vigilant, okay? You have to be very aggressive in treating these patients because pag hindi nyo na-treat ang vegetations na yan, it can further damage the valves, okay? So what are the most common portal of entry? It would be your dental procedures occurring in about 15 to 20%. And some patients who undergo GUT or genitourinary tract or gastrointestinal tract instrumentation, okay, they can have this portal of entry. Let's say 50% are caused by your enterococci. Okay, some patients can have abscesses or some conduction abnormalities, fistula, or even rupture of your chordae tendineae. So what will usually happen? You can have these emboli, okay, especially in your right-sided endocarditis. Most commonly in patients who are IV drug users because it is the tricuspid valve that are more commonly involved. Okay, when you say it's mycotic aneurysm, these are your septic embolization to your vasa vasorum or direct bacterial invasion of your arterial wall. So sometimes they cause rupture, okay, of your cerebral arteries, your aorta, the ligated ductus arteriosus, or even your blood vessels on your GI tract, okay? So if you have this infective endocarditis, you have these high circulating immune complexes, meaning some patients who presents with glomerulonephritis, okay? For those patients having myocarditis, they can also have this small coronary artery emboli, some myocardial abscesses, or even immune complex vasculitis. So it's very broad, okay, if you have this endocarditis. So what is the most common manifestation of these patients? They usually start within 2 weeks of your precipitating event, okay? Since viridans is strep, so they are usually subacute, so it has low pathogenicity. It is gradual onset with mild fever and malaise. While your staph aureus, which is your acute infective endocarditis, they have high pathogenicity with acute onset with high fever. So what are these? So these are the common peripheral manifestations of patients having infective endocarditis. What is this? So this is your splinter hemorrhages. Okay, sometimes reddish po muna yan, and then after a while it turns into brown. So this one is your conjunctival hemorrhage. Okay, this will be your ocular nodes. Okay, it is more located here on your thenar area. So they are tender, they are subcutaneous nodules, okay? Usually occurring on the top of your digits. Next is your Janeway lesions, okay? They are the non-tender erythematous, hemorrhagic, or pustular lesions. They are often located at your palms or your sole area, okay? So pag nakakita na kayo niyan, okay, some are caused by your immunologic presentations of your infective endocarditis. So this one, subungual hemorrhages, okay? This is your Roth spots. So retinal hemorrhage with pale center yan. Okay, clear center. And your conjunctival decay. Mostly ang nakikita namin sa mga patients with infective endocarditis are your, this one. Okay, some patients presents with Janeway lesions. Wala pa akong masyadong nakita. I haven't seen from my IE patients presented with this ocular nodes. Some presented with this, okay? Yung mga linear erythematous or reddish color on their nose. So splinter hemorrhages yan. So this is actually a large vegetation, okay, from the mitral valve annulus. Okay, so this is your mitral valve leaflet. This is your papillary chordicandinae. Okay, so andito yung mga papillary muscles nila. So pag na-rupture yan, if this has been ruptured, causing mitral regurgitations. Okay. So this one is a prosthetic valve that has been removed. Okay, because of their enterococcal prosthetic valve endocarditis. So, pag nagkaroon yan ng vegetation, okay, it will be more fatal to the patients kasi nag-block na siya. So, especially in the aortic valve, most commonly, it can cause embolization. Okay. So, what will be the manifestations of infective endocarditis? Fever, okay, almost present in all cases, and it is the most common signs and symptoms. However, sometimes you can have this fever in elderly or those patients with renal failure or congestive heart failure or patients having severe disability. Okay, common din sila na magkaroon ng arthralgia and even arthritis. Okay, sometimes one would be your diagnosis would be your rheumatic fever, okay, because sometimes it presents with joint pains, fever, and then when you check if there's presence of new murmur, or if let's say if this patient has already known case of rheumatic heart disease and damaged valves already, then you might do your ASO, your inflammatory markers, okay, because that will lead you for your correct diagnosis. So some manifestations would be your cardiac murmurs, okay? They are almost always present, okay? However, in patients with early in acute endocarditis, hindi nyo pa yan maririnig because it's very early pa. So meaning hindi pa ganon ka-damage yung valves nila. Or to those patients who have tricuspid valve infection, especially in IV drug users, okay, hindi nyo pa rin sila masyadong maririnig yung murmur. So the changes in murmur are rare, okay? Mechanisms that are present, okay? So if there's also presence of histologic exam and the culture of emboli. So this is the modified Duke criteria for your diagnosis of infective endocarditis. Okay, so we have the major criteria. So how do you diagnose patients with infective endocarditis? So parang yung sa Framingham's criteria natin. Okay, so you should, patients who are diagnosed to have definite, okay, if you have definite endocarditis, they should fulfill two major criteria, one major criteria, and three minor criteria or five minor criteria. If they are only possible infective endocarditis, then they can fulfill one major criteria and one minor criteria or three minor criteria. Okay? So if you have definite, two major, one minor plus three minor criteria. So what are the major criteria? So microbiologic, okay, if there's presence of positive blood culture, kapag ang tumubo dyan, ito ang mga yon, let's say viridans, streptococci, okay, staph aureus, enterococci, or those patients or those microorganisms that are consistent with infective endocarditis isolated from persistently positive blood cultures. Or let's say single blood culture of your Coxiella burnetii, okay? Or if there's evidence that is only your microbiologic, okay? Let's say in the evidence of your endocardial involvement, there will be new valvular regurgitation, okay? Presented as your new murmur, okay? Let's say you do your 2D echo, and then by doing trans-esophageal or even trans-thoracic echocardiogram, okay, nakita mo na yung vegetations mo. Or let's say patients, you do TEE actually for patients who underwent prosthetic valve surgery. Kasi sometimes hindi namin nakikita if you only do your trans-thoracic. That's why we need the trans-esophageal, okay? Or let's say if patients have complicated infective endocarditis, okay? So what about the minor criteria? So when you say it's minor criteria, if there's predisposition to have this infective endocarditis, let's say they have high-risk conditions such as they have previous IE already, patients with aortic valve diseases, rheumatic heart diseases, prosthetic valve, coarctation of aorta, and those patients with complex cyanotic heart diseases. Okay? Meron silang predisposing factor. So, positive yan. So, that is already considered as your minor criteria. So, what about the moderate risk conditions? Patients with mitral valve prolapse, with valvular regurgitation. Okay? If you saw any leaflet thickening, okay? Kasi pag meron kang leaflet thickening, it actually suggests more of rheumatic heart disease. Patients who have isolated mitral stenosis, tricuspid valve, pulmonic stenosis, and hypertrophic cardiomyopathy. However, for low or no risk conditions, those patients who have simple congenital heart disease such as your ASD, patients who have underwent bypass surgery, the patients with ischemic heart disease and mitral valve prolapse with thin leaflets in the absence of regurgitation. Let's say only mitral valve prolapse, however, there is no mitral valve regurgitation, they are considered as low or no risk conditions. Okay? Patients who have fever, okay, more than 38 degrees yan. Vascular phenomena, na yung mga vascular phenomena, you have dyspeptic and splinter hemorrhages. What about the immunologic phenomena? Okay, presence of your rheumatoid factor, glomerulonephritis, your osseous node, and your Roth spots. Microbiologic findings, positive blood culture that do not meet the major criteria. Okay, kung pasok doon sa criteria nyo, so that is definite. Okay, pag hindi siya pasok doon and it's only possible, meron din siyang criteria. Okay, but these are the major and your minor criteria. So, i-memorize nyo ito because ito yung usually lumalabas sa mga exams and even board exams. So, of course, if you have infective endocarditis, okay, we usually need prophylaxis. So what are the conditions that we need prophylaxis? So as what we have mentioned earlier, yung mga high-risk category, so those patients underwent valve surgery, okay, mga may prosthetic valve, patient who had previous bacterial endocarditis, complex cyanotic congenital heart diseases like your TGA, tetralogy of Fallot, okay, mga single ventricle states, okay, those patients who had surgically constructed systemic pulmonary shunts or conduits. Usually, ginagawa ito sa mga tetralogy of Fallot. So they belong to the high-risk category. That's why, let's say, if they will proceed with any surgery or any dental procedures or kahit na anong GIT or GUT, you still need to give endocarditis prophylaxis. We will be tackling that later on. So what about the moderate risk category? So other than what we have mentioned, the congenital cardiac malformations earlier, okay? Patients who have rheumatic heart disease, they belong to this category. Patients who have HOCM, hypertrophic cardiomyopathy, mitral valve prolapse with valve regurgitation, or thickened leaflet. So moderate risk ang mga yan, ha? So what are the procedures that will be needing prophylaxis? Let's say dental extractions, okay? Bakit kailangan natin ng prophylaxis? Why do we need prophylaxis, especially in dental extraction? Of course, because dental extraction would be your portal of entry, okay, for you to have this infective endocarditis, especially if you have predisposing factors already. Let's say congenital heart disease and rheumatic heart disease. So patients, basta sa mga bibig yan, okay, dental extractions, periodontal procedures, let's say root planning, okay, dental implantation, instrumentation or surgical only beyond the apex. Okay, so these are the different dental procedures. Okay? Pero pag mga pasta lang, okay, if only dental filling, there's no need to give actually prophylaxis. Okay, I need to emphasize this one. Prophylactic cleaning of teeth or implants where bleeding is anticipated. Okay, so you have to give endocarditis prophylaxis. So what about the conditions or the procedures that does not need recommendations of your prophylaxis? Ito yan. Okay, mga local anesthetic injections, mga placement lang of your rubber dams. Okay. So removal of your post-operative sutures, no need. Taking of oral impressions fluoride treatments, no need. Oral radiographs, orthodontic appliance adjustment, or shedding of your primary teeth, there's no need. Okay. So prophylaxis is recommended for high and moderate risk cardiac conditions. Okay. Not recommended restoration of decayed teeth. Let's say filling cavities and placement of your missing teeth. Okay. So we do clinical judgment who need your antibiotic prophylaxis. Okay. In some selected circumstances. So what about patients who are undergoing procedures on the respiratory tract? It is recommended. Okay. Tonsillectomy, adenoidectomy, bronchoscopy with a rigid bronchoscope, who are at high and moderate risk category, you give prophylaxis. For patients undergoing GUT tract surgery procedures, prostatic surgery, cystoscopy, or urethral dilatation, indicated sila. Okay. So what about patients where prophylaxis is not needed? Let's say endotracheal intubation, okay, no need. Bronchoscopy with a flexible bronchoscope, there's no need. Only for patients with bronchoscopy with rigid, okay, bronchoscope, you need that, okay, because of the possible complications, you might do perforations, okay? So yun yung binibigyan natin ng prophylaxis. Yung mga transesophageal echocardiography, endoscopy with or without gastrointestinal biopsy, no need for prophylaxis. So vaginal hysterectomy, vaginal delivery, however, in the presence of moderate to high risk, you still need prophylaxis in these two procedures, okay? Mga IFC insertion, okay, urethral catheterization, dilatation curettage, therapeutic abortion, sterilization procedures, no need, okay? So some cardiac catheterization like your percutaneous coronary intervention, just like your balloon angioplasty or implantation of your cardiac pacemakers or your ICD and stents, incision or biopsy of surgically scrubbed skin circumcision. No need, okay? So what will be our prophylactic regimen? So ang most common na ginagamit natin would be your amoxicillin, okay? 2 grams yan. So ang available lang naman is 500 milligrams. So we usually give 4 tablets, okay? 1 hour before the procedure. Ito lang tandaan nyo. For children, 50 milligram per kilogram orally, okay? However, for those patients who cannot tolerate the amoxicillin, okay, you can give the ampicillin 2 grams IM or intravenously 30 minutes before the procedure, okay? So this is very important. This is what we usually give for our patients. What about patients who are allergic to penicillin? So you can give other options, clindamycin 600 milligrams, okay, 1 hour before the procedure. Cephalexin 2 grams, azithromycin 500 milligrams, clarithromycin, okay, that's 500 milligrams also, 1 hour before the procedure. Hindi na ako actually nagbibigay ng cephalexin. I do not give cephalexin, especially if this patient is already allergic to penicillin, okay, because it has also penicillin component. So clindamycin, what about for the dental, oral, respiratory, or esophageal? So you can still give clindamycin, cephalexin. Okay, it's almost the same lang. Ito lang tatandaan nyo. Okay, so allergic to penicillin, you can have these options. Okay, but the general prophylaxis will be your amoxicillin, 2 grams, 1 hour before procedure. Okay. So what about patients who are undergoing genitourinary or GI tract, except for the esophageal procedures? Okay, you can give for high-risk patients ampicillin plus gentamicin. Okay, ampicillin 2 grams IM or IV, then you give gentamicin 1.5 milligrams per kilogram, as long as there's no contraindication. Okay. Ampicillin 1 gram orally, okay, or gentamicin 1.5 milligrams per kilogram within 30 minutes of starting the procedure, and then 6 hours later, you give your ampicillin 25 milligrams per kilogram IM or IV. Okay, or amoxicillin yan. Huwag nyo nang tandaan to. Ang adult lang kasi yung binibigay namin. It's nice to know, but mostly, for high-risk patients, we give your ampicillin 2 grams and gentamicin 1.5 milligrams per kilogram. Okay? For the moderate-risk patients, amoxicillin or ampicillin pa rin yan. Ha? So 2 grams, amoxicillin, gentamicin, still the same, 1.5 milligrams per kilogram IV or IM. Okay? So what are the indications for surgery in patients with infective endocarditis? Okay, let's say after treating with antibiotics, the response is still poor or there's presence of relapse with persistent blood culture, then you proceed with surgery. Okay? In the presence of fungal endocarditis na yan, nakita mo may candidiasis na siya. Okay? That's already considered indication for surgery. Patients who have severe heart failure, there's presence of abscess, okay? You do surgery for drainage. Patients who have large vegetation that is more than 10 millimeter, okay? Because of takot tayo for the emboli, and they present with obstruction yan. So once there is obstruction, like LV outflow tract obstruction, then there will be decrease in your cardiac output. It is very fatal, okay? So prosthetic valve dehiscence or severe dysfunction. Okay, natanggal yung prosthetic valve mo, nasira because of the infective endocarditis, then you need to repair it. So based on the American Heart Association, these are the following recommendations for diagnosis and follow-up of patients with infective endocarditis. Okay, you do your at least 2 sets of your blood culture. Okay, that's class 1 indication. For those patients who are at high risk for infective endocarditis, such as congenital, previous IE, patients with prosthetic heart valve, patients who have congenital or heart malformations, immunodeficiency state, or injection drug users who have unexplained fever for more than 48 hours. Okay, so you get blood cultures also for newly diagnosed left-sided valve regurgitation. So pag may narinig kang new murmur, okay, and it's mostly on the right side, you get two sets of your blood culture. And if the modified Dukes criteria should be used in patients with suspected infective endocarditis. Okay, once you have evaluated infective endocarditis, then you might manage or consult these patients to a multi-specialty team consisting of IDS, cardio, and your surgeons. Okay, and if there's a need for surgery, then you have to refer them for cardiac anesthesiologists. So transthoracic echocardiography recommended, it's class 1 recommended for patients with suspected IE. For you to identify vegetations, okay, to characterize the severity of the valvular lesions, you assess the ventricular function and even detect any complications. So let's say hindi non-diagnostic yung transthoracic echocardiogram, then that's class 1 recommendation to do your transesophageal echocardiogram, especially for patients who have prosthetic valves or those patients who have intracardiac device leads. Okay, so transthoracic or transesophageal, they are recommended for re-evaluation of patients with IE who have changed in clinical symptoms. Okay, let's say you are treating the patients already and then they presented with new murmur, there's presence of embolism, persistent fever, or they go into heart failure, or even block. Okay, then you do again your transthoracic or transesophageal echocardiography to check for any extensive vegetations or infective tissue on your initial echocardiogram. Okay, so we do intraoperative transesophageal echocardiogram, especially for patients who are undergoing valve surgery. Okay, so when you do valve repair or replacement, after they place the valves, okay, we do the intraoperative TEE before we close the patient, okay? Because sometimes there are presence of leak or even some, let's say, damage to the annular or annulus of that certain valve, okay, ma-repair pa rin nila. So to class 2A, okay, they are maybe reasonable that it is recommended to do TEE to diagnose possible infective endocarditis for patients with Staph aureus bacteremia without a known source. Okay, so TEE for prosthetic valve in the presence of persistent fever without bacteremia or a new murmur. It's class 2A recommendation only. So, of course, it is class 1 recommendation that we give our appropriate antibiotic therapy. Okay. So, it's class 2B. Okay. Let's say this patient are already on oral anticoagulation. Okay. It is reasonable to temporarily discontinue in patients with IE who develop central nervous system symptoms compatible with embolism or stroke, regardless of other indications of anticoagulation. Okay. So, patients with known valvular heart disease should not receive antibiotics before blood culture are obtained for unexplained. So, it is class 3 recommendation. Yan ha, hindi na natin yan ginagawa. Okay? So, decisions about timing of surgical intervention, it should be made by your different subspecialties. Okay? So, may consensus dyan. Early surgery is indicated in patients with IE who presents with valve dysfunction. So once there is heart failure, ano yung mga indications natin for surgery? Large vegetation, okay? May heart dysfunction ka na, okay? So you already do early surgery. Okay, so early surgery, ito yan. In the presence of fungal na yan, okay, automatic na yan, early surgery ka. Patients, early surgery is indicated in patients with IE complicated by heart block, annular or aortic abscess, okay? If there's presence of penetrating or destructive lesions, okay, you do surgery. Okay. So persistent bacteremia or fever lasting longer than 5 to 7 days after giving your appropriate antimicrobial therapy. Surgery recommended for patients who have prosthetic valve endocarditis and relapsing infection. So what is relapsing infection? Meaning there is recurrence of your bacteremia after the complete course of your antibiotics and subsequent negative blood culture. Okay. So let's say if there's presence of IE, then you have to remove in the presence of pacer and ICD, meron sila, kailangan tanggalin. Okay, we have to remove the pacemaker or defibrillator systems. Complete removal of pacemaker or defibrillator, including all the leads and the generator, is reasonable in patients with valvular IE caused by staph aureus or fungi, even without evidence of device or lead infection. Okay, only it's class 2A recommendation. Okay, so this will be our algorithm. Patients who are at high risk or suspected native valve endocarditis or prosthetic valve endocarditis, you obtain blood culture, 2 sets, okay? You do your transthoracic or transesophageal, and then if it meets the criteria of your modified Dukes criteria, be it definite or probable IE, okay? You start class 1 indication that you start them on antibiotics, okay? So what about evaluating the patients for the need or the timing of your surgery? If there's presence of valvular dysfunction, resistant organism, presence of heart block or abscess, persistent infection, and relapsing prostatic valve surgery, then you do your surgery, okay? Presence of large mobile vegetation, you do also your surgery. Recurrent emboli and persistent vegetations, despite appropriate antibiotic, you do surgery, but it's only class 2A recommendation. In the presence of pacer or ICD, which is present, and there is infection of the leads or device, then you do your surgery, you remove the hardware early. Okay? Okay, so ito yung algorithm natin for infective endocarditis. We may move on to cardiac tumors. So cardiac tumors, for the primary cardiac tumors, they are very rare, okay? 20 to 40% times more common if there is secondary involvement of the heart by extracardiac tumors. So if it comes from the heart itself, primary yan, very rare yan na nagkakaroon tayo ng cardiac tumors. So mostly, they are considered as secondary involvement lang. So 75% of patients who have benign neoplasm is caused by your cardiac myxoma, and 25% are considered malignant. The most common would be your sarcoma. Okay, so they present with non-specific symptoms. They mimic disease entities. Okay, just like in myxoma, okay, they mimic disease entities just like your mitral stenosis, okay? Kasi pwede silang nag-o-obstruct doon when your heart contracts, there is oscillating movement of your myxoma going to your mitral valve, okay? Then there will be obstruction of your left ventricular obstruction from your left atrium going to your left ventricle, mimicking your mitral stenosis. So they may, in the patients with mitral stenosis, ano yung mostly common symptoms nila? Okay, they can have angina, okay, they can have syncope, okay, because of your decreased stroke volume and cardiac output, okay? So the use of your non-invasive imaging modalities, just like your 2D echo, will facilitate the identification of your cardiac lesions. So they present with systemic manifestation. They can have embolic phenomena, okay? Kasi pag na-dislodge yung mass mo, they can cause embolism. Cardiac manifestations, just like your myxoma, MS manifestations. So you can have angina, you can have syncope, okay? Metastatic diseases, okay? They present as metastatic diseases. So these are the different kinds of your benign primary cardiac tumors. So the most common in adults would be your myxoma. But in children and infants, the most common would be your rhabdomyoma, okay? So this is how your cardiac myxoma looks like. Usually they are located on your left atrium. This is the most common benign, okay? They are present in 30 to 50 years of age. 75% are present on your left atrium. So meron pa rin kami nakikita actually that are located on your right atrium, but it's very rare. And then the site of attachment would be your limbus of your fossa ovalis. Okay? So if they are less often located actually on your left and your right ventricles. Why? Kasi pag may nakita ka dyan, if you have seen echogenic density actually on your left ventricle, then meaning this is not a mass. This might be considered as thrombus, especially in the presence of ejection fraction of less than 35%, and then there's presence of hypokinesia or akinesia of your different segmental wall motion abnormalities, then you might consider them as thrombus, okay? Hindi siya myxoma. 90% of them, they are solitary, and then the average size is about 5 to 6 centimeter. Okay. So treatment would be your surgical. Okay, this is your myxoma. Okay, recurrence 1 to 5%. That's why it is important for us to do the annual surveillance. You do your 2D echo yearly. Okay. However, in the presence of familial carni complex, the risk of recurrence will be 12 to 22%. So eto yun, if you have familiar carni, they have thyroid problem, they have hyperpigmentation on the oral mucosa, they have left atrial myxoma. Okay, they belong to that group. Recurrence mo is mas mataas. So what about the malignant primary cardiac tumors? So the most common would be your angiosarcoma in adults. And then for children and infants, most common would be your rhabdomyosarcoma. Okay? So sila yung mga common malignant primary cardiac tumors. However, for malignant cardiac tumors, less common sila as compared with that of the metastatic diseases. Okay? So they tend to invade or replace the myocardial tissue with disruption of normal anatomy. And commonly, if you have malignant primary cardiac tumors, they are usually associated with pericardial effusion. Okay? The angiosarcoma usually involves your right atrium, and rhabdomyosarcoma, they can occur anywhere. So what about the metastatic diseases to the heart? So sila ang more commonly seen, okay, compared with your malignant primary tumors of the heart. Okay, so metastasis can manifest in the heart as a mass, okay, pericardial diseases or myocardial involvement. So the most common actually na nakikita namin would be mass actually on your right side. If there's presence of let's say right atrial mass or right ventricular mass, isa lang iniisip namin dyan, maybe this is metastatic. And sometimes they are associated with pericardial effusion. Okay? So tumors can actually spread to heart by direct invasion. They spread through venous system or hematogenously. So cardiac involvement is established at autopsy in patients with otherwise widely metastatic diseases. So ito yung mga different primary malignancies with their different cardiac effects. So sa lungs, okay, it can cause direct extension, can have pericardial effusion. Sa breast, okay, since they are hematogenously lymphatic spread, effusion pa rin yan. So most likely, if you have metastatic diseases to the heart, nagpe-present sila actually ng pericardial effusion. Okay? For your lymphoma, this is lymphatic spread, GI, variable, melanoma, intracardiac or myocardial involvement. Ito yon, mostly seen namin to, renal cell carcinoma. They can have actually right-sided mass lesions yan, okay? IVC, right atrium, right ventricular extension, then they can actually look thrombus. So for the carcinoid, usually on the right side also. Tricuspid and pulmonic valve abnormalities yan. Pag sinabi mong carcinoid, usually mga calcifications yan. Okay? I think that's my last slide. So, thank you everyone for listening. So, tapos na tayo sa IE and even yung cardiac tumors. Any questions?
Doc, question po. Doc, sa removed hardware, parang yung tinanggal na pacemakers, ibabalik po ba siya or bagong unit na po ilalagay?
Yung mga may pacemakers na nagkaroon ng infection?
Yes po, Doc.
Tinatanggal yun. Kasi pag ibabalik din namin, nandun pa rin yung source ng infection mo. Tinatanggal talaga namin yun. Even the generator sometimes. Yun nga lang, mahal.
Okay, thank you po, Doc.
Okay. Any more questions? Clarifications? Wala na? So, importante ha na once nag-present sa inyo yung patient, prolonged fever, okay? Let's say there's no predisposing factors, kasama pa rin dyan, fever of unknown origin, okay? You do your, it's class 1 recommendation that you do your non-invasive imaging if you suspect for infective endocarditis. Lagi yan. Infective endocarditis would be the #1 differential diagnosis if the patient present with prolonged fever yan. And hindi nila ma-diagnose kung saan nanggagaling. Let's say they did already the different laboratory workup, wala silang ma-pinpoint, okay? You do your to the echo. Of course, you do also your physical examination. Kasi by doing clinical, baka may ma-pick up ka na. Let's say, new murmur, okay? You also have to ask if this patient is using, okay, IV drugs, okay? Madalas yan. Kasi minsan hindi nila sinasabi that they are taking, using IV. May patients kami actually na ganyan. So, highly suspicious siya. So, we did actually the to the echo and it turned out meron siya on the right side, tricuspid valve endocarditis talaga. May vegetation on the right side. So, kinonfirm namin and then doon lang siya nag-confirm sa amin that he is actually IV drug abusers. Okay? So, may patient din ako, aortic regurgitation ang presentations, heart failure presentations, okay? It's already grade 3 to grade 4 yung murmur niya. And then when I did the to the echo, there's already perforation of the aortic valve. So I advise this patient actually to undergo aortic valve replacement, pero ayaw niya. So I treated this patient medically only, okay? We treat the infection, the vegetations, okay? Since ayaw niya, we only give medical therapy. So nabuhay pa naman siya for 4 years. Recently lang siya nawala, pero nag-refuse na kasi siya ng any further interventions. So even medical treatment, ayaw na niya. So nag-congest, wala na, bumigay na siya. Okay? So if there are no more questions, thank you for listening. And good luck on your next exam. So isasama ko na lang yung infective endocarditis siguro sa next na long exam nyo. Maybe I can ask, tanungin ko na lang sa office kung ilan yung points na ibibigay ko. Okay? Let's see. Okay. So, thank you everyone. Have a nice day.
Thank you po.
Thank you po, Doc.